Good morning. I hope you'll forgive me for speaking in English. I will try to speak slowly and clearly. I'm so grateful for the invitation to be here. It's a wonderful honor and pleasure. I was asked to start by talking a little bit about the management of the axilla and specifically regional lymph node radiation after preoperative systemic therapy or neoadjuvant systemic therapy. So by way of background, when I was doing my training, and I think historically the way that we have always thought about the role of preoperative systemic therapy has been to improve surgical options and trying to take patients who may have presented with unresectable breast cancers and make those tumors resectable, or take a patient who may require a mastectomy based on the size of their tumor up front and try to shrink that tumor so that they can become a candidate for a breast conservation. And then more recently, the opportunity to decrease the extent of the surgical intervention in the axilla and take a patient who presents with lymph node positive disease, who we might normally think of as requiring a full axillary dissection, and downstage with the preoperative chemotherapy to allowing them to have the less morbid sentinel lymph node biopsy. But more recently, as we have developed more targeted systemic therapies and learned which tumors have a greater likelihood of responding to certain preoperative systemic regimens, we have also started to view preoperative systemic therapy as an opportunity to sort of watch the chemotherapy in action and evaluate the sensitivity of the tumor to chemotherapy. I mentioned this NeoSphere study, which was the study that evaluated the role of preoperative trastuzumab with pertuzumab, so dual anti-HER2 therapy in patients with HER2-positive breast cancers. And the addition of the pertuzumab increased the rate of complete pathologic response from about 30% to nearly 50%, and even greater than 60% in those patients that had estrogen-negative and HER2-positive disease. So in the US, this trial was a very significant milestone because the FDA approved the utilization of pertuzumab on the basis of observing this pathologic complete response. So the study at the time was only looking at this short-term endpoint of complete response, has not had enough follow-up to assess if there is any survival advantage. There has not been shown yet to be a survival advantage, but just because of the improved response, the drug was approved. So this is sort of a shift in thinking about the role of preoperative systemic therapy, that we can evaluate how effective it is in the tumor. And then from the perspective of the radiation oncologist, we are increasingly utilizing the response to preoperative systemic therapy to help us tailor our radiation decisions. Historically, the majority of the data that we use to determine if a patient needs radiation after mastectomy or needs lymph node radiation has come from patients who have surgery, and we make that determination based on their pathology, how large the tumor was, how many lymph nodes were involved. But when we have patients who receive preoperative systemic therapy and the tumors shrink or there are complete pathological responses, our traditional criteria for using radiation are blurred. And so we are in a whole new era of needing to understand how the impact of or what the impact of responding to preoperative systemic therapy should be on our radiation decisions. And I would argue that we are moving towards using the response to preoperative systemic therapy to help us consider omitting post-op mastectomy or regional lymph node radiation in some patients who might have automatically been thought to require it prior to having had preoperative systemic therapy. and then also identifying the most high-risk patients that we should probably continue to use post-mastectomy and regional lymph node radiation. So I wanted to spend a little bit of time at the beginning talking about pathology and specifically how the response to preoperative systemic therapy should be evaluated. Because as radiation oncologists, we're very often in the position of needing to make a decision about radiation, being given a pathology report saying the patient had a complete response or had an incomplete response. And because it's so impactful on our own decisions, I think it's very important that we're thinking about, well, how is the pathology evaluated, and are we confident that we have enough information to make the correct decision? So this slide is looking at the response within the primary tumor, and it just highlights that there are different ways that the primary tumor can respond to preoperative systemic therapy. In the setting of a complete response, where there is no residual tumor that is identified, one of the key features would be to see whether a tumor bed was identifiable, whether a biopsy clip was left behind and can be retrieved to confirm that you've in fact got the right area, or other pathological evidence of where the tumor was located. In addition, this slide highlights that the tumor can respond in many different ways. It can shrink concentrically, meaning completely symmetrically. It can shrink in maybe only one dimension. It can stay the same size, but the cellularity or the density of the cancer cells can decrease. And having as clear an understanding as possible of exactly what the tumor response was will help us in understanding the extent of how the tumor responded to chemotherapy. But I think we make most of our decisions based on whether there was a pathologic complete response or not. And so we want to be confident that the tumor bed could be identified, so we're sure that we observe that complete response. I think more importantly, affecting our management is assessing the axilla after preoperative systemic therapy. And so I wanted to focus on how we assess the axilla. So there are a number of features that can affect sort of the quality or the sensitivity of a sentinel lymph node biopsy after preoperative systemic therapy. One of them is having had a prior sentinel node biopsy, and I'll show some data on that. The clinical status prior to chemotherapy, whether the patient had clinically apparent lymph nodes or not, the number of lymph nodes that are retrieved, and how they're identified, are just a few that I'll highlight. So the first thing I want to just say is that for patients who present with clinically node-negative disease, meaning that there's nothing abnormal on physical exam, and if there is any preoperative ultrasound or other imaging of the axilla, if there's nothing that appears abnormal, the data suggests that the reliability of a sentinel lymph node biopsy should be just like a patient who goes straight to surgery and has an upfront sentinel lymph node biopsy. So a standard sentinel lymph node biopsy should be sufficient even after preoperative systemic therapy in those patients who have no evidence of lymph node involvement up front. We know that some of them may have occult disease that we don't appreciate, but the reliability of the sentinel lymph node seems to be in line with what you would expect for an upfront biopsy. The question that has come up is whether or not you can do a sentinel lymph node biopsy at the beginning and then repeat that sentinel lymph node biopsy if it's positive, if the sentinel lymph node was positive, repeat it after preoperative systemic therapy in an effort to see did the lymph nodes respond and can we potentially avoid a full axillary dissection. So the Sentina study asked this question in this Sentina was a randomized study that had 4 different arms. There was one group that was clinically lymph node negative, meaning nothing palpable, and then another group clinically lymph node positive. And so in the clinical node negative group, one of the questions was about the role of repeating the sentinel lymph node biopsy. And in those patients who had a sentinel lymph node biopsy and then subsequently had that procedure repeated after preoperative systemic therapy, the false negative rate was over 50%. So this was a very humbling result, suggesting that the sentinel lymph node procedure really can only be done reliably one time, and that if a sentinel lymph node biopsy is done prior to chemotherapy, in many ways we have to act on that result because we're not going to be able to interpret a subsequent one. So we have moved away from doing a sentinel lymph node biopsy at the beginning and rather rely on the physical examination and a needle biopsy if there is any suspicion. Moving on to patients who have clinically apparent lymph nodes at the time of diagnosis. That's the second group of patients in the Sentina study. This is questioning for those who we know have lymph nodes that are involvement up front, can we reliably do a sentinel lymph node biopsy after their systemic therapy? And the Sentina study and a couple of other studies that I'll go over right after this demonstrate that, yes, we can do a sentinel lymph node biopsy after preoperative therapy, but that there are specific criteria that have to be met in order for it to be reliable. What the study showed was that overall, if no special criteria were met, the false negative rate was around 14%. And we have sort of defined getting under 10% as what should be clinically acceptable based on the sentinel lymph node data from patients who go straight to surgery. So that false negative rate of 14% is considered unacceptably high. But within the study, there were criteria that could be met to help reduce that rate under 10%. And I think the most important one that is consistent through all the studies is retrieving multiple lymph nodes. And in this study, retrieving 3 or more lymph nodes allowed the false negative rate to be less than 10%. The same findings were identified in the ACOSOG Z1071 study, which is basically like a mirror image of the Sentina Arm C. And again, if 3 lymph nodes or more were retrieved, then the false negative rate was less than 10%. There were other criteria as well, as shown on the slide, such as using dual tracer, radio tracer, and blue dye. And then finally, a third study, the SNFNAC study, also had very, very similar results. In their case, they required immunohistochemistry, and by utilizing that, the false negative rate was very low with the identification of only 2 sentinel lymph nodes. So as radiation oncologists, I would just argue that it is very important if we're going to make a decision based on the axillary response to systemic therapy that we very carefully review the history, the pathology report, and the sentinel lymph node procedure in order to be confident that we have a reliable answer to the question of whether a pathologic response was achieved. And again, there are a lot of features shown on this slide, but I think the most consistent one that's the most straightforward is just simply the number of lymph nodes. 1 sentinel lymph node after preoperative systemic therapy is going to have a relatively high false negative rate. Most of the randomized studies, RTOG studies, will say there's a requirement of 2, but I would say 3 is even better. Moving into the pathologic response by subtype, I'm sure we're all familiar with this, but there is quite a bit of variability in terms of how different subtypes respond to preoperative systemic therapy. with triple-negative tumors being highly sensitive, and luminal A and estrogen-positive tumors being less so, having a lower likelihood of responding. And then coming back, I already mentioned this data, but the triple-negative and then HER2-positive tumors, particularly in the setting of dual HER2 therapy, trastuzumab and pertuzumab, have a very high likelihood of responding to preoperative systemic therapy. But what I think is very interesting is that the significance of that response is also variable. And so this is some data to identify, for example, in luminal A patients who are shown in this box, that the disease-free survival over time, as shown in the blue versus the yellow lines, really isn't significantly different for those who have a pathologic complete response and those who don't. They tend to, these are low-risk tumors that tend to do well over time, even when they don't have a complete response to preoperative systemic therapy. So sorry, just going back, we have a very low likelihood of achieving a pathologic complete response in a luminal A patient. But failing to achieve that doesn't necessarily have a big impact on their outcome. Whereas in, for example, the triple negative in the bottom box here, not having a pathologic complete response is associated with a much poorer long-term outcome than having one. So that's also an important thing for us to think about is how important is that pathologic complete response. Moving into local regional recurrence after preoperative systemic therapy, this is kind of an evolution, I think, over time. The very earliest data from MD Anderson basically just showed us that tumors that are persistent after preoperative systemic therapy are like worse players, have a greater risk of recurrence than those that are staged up front. So just as an example, if you have a 5-centimeter tumor up front that has not as high of a risk of as a 5-centimeter tumor that's remaining after preoperative systemic therapy. Most of the very early data on preoperative systemic therapy came from MD Anderson, and in those studies it was shown that the risk of recurrence was decreased in patients who had a pathologic complete response, but was still relatively high. And so the very early studies that had a predominance of locally advanced stage 3 patients suggested that we should really, I have this on a slide, suggested that we should make our decisions based on their pre-treatment staging and that the response to preoperative systemic therapy was less important. But again, these studies were heavily weighted with patients with stage 3, sort of more locally advanced disease. More recently, data from France and from Korea, these are very parallel studies, looked at patients who predominantly had stage 2 disease, who converted from lymph node positive to lymph node negative after preoperative systemic therapy, and showed that the risk of local recurrence was relatively low even without radiation. The two curves here are with and without radiation in patients who converted from node positive to node negative after preoperative systemic therapy. So this starts to call into question whether all of these patients who present with node positive disease really need post-mastectomy or regional lymph node radiation. Finally, the NSABP has a pooled analysis of patients who were treated on preoperative studies, and there are 3,000 patients. What is good about this study is that all of the patients in these studies who had mastectomies did not have radiation. So we have a pure data set of patients who had preoperative systemic therapy, had mastectomy, did not have radiation, so we can see what happens. But one of the downsides of this study is that it did not have a lot of information about receptor status, which we've learned is so important. So it has some pros and some cons. But the results showed that for patients who converted to either pathologic complete response or to lymph node negative after having had, particularly on the right side of the panel, you can see clinically node positive, had very low rates of recurrence, generally speaking less than 10% if the patient converted to lymph node negative after preoperative systemic therapy. It's important to note that there are relatively small numbers of patients in these subgroups. What we're looking at here is patients who had tumors less than 5 centimeters, and this slide is a similar slide, tumors greater than 5 centimeters. So the risks in this slide, as you can see, are a little bit higher, but still those patients that convert to node negative have risks of recurrence of less than 10%. And again, these are all patients who did not have radiation. I'll briefly mention the CTNeoBC pooled analysis, which, just like the NABPC, has some limitations. It is a pooled analysis of neoadjuvant chemotherapy studies. Its benefit over the other data is that it does include receptor status, but the downside is that it doesn't, there was variable use of radiation, so it's a little bit hard to conclude from this. But what was interesting just looking at subtype here is that for patients who were hormone receptor positive, those who had low-grade tumors had a very low risk of recurrence, either with or without a pathologic complete response, whereas in the bottom, the grade 3 had a very low 0% risk of recurrence for pathologic complete response, but almost 14% with residual node positive disease. So showing that grade is a big variable for these ER/PR positive HER2/neu negative patients. And then in triple negative, as we saw before, that the response, even with a pathologic complete response, the risk was higher, and with residual nodal disease, risk is very high. So to just summarize, there are multiple factors that would be seen as risk factors for local recurrence after preoperative systemic therapy. Presenting stage being very important. Stage 3 patients, regardless of their response, seem to have a poorer outcome. Receptor subtype, grade in the luminal subtypes. And also the extent of the pathologic response, the utilization of modern tailored systemic therapies, and other traditional features for local regional recurrence. The last thing I'll just highlight is the current research studies. The NSABP B51 is the current randomized study that looks at this population. We start with patients who have biopsy-proven lymph node involvement at the time of diagnosis. They receive preoperative systemic therapy, and if they convert to lymph node negative, and harking back to the sentinel lymph node biopsy, they need to have 2 lymph nodes at a minimum removed. If they become node negative, they are randomized to receive regional lymph node radiation or not to. And so this will hopefully help to clarify the question. I'm just skip to the last slide. So just to summarize, the question of omitting nodal radiation after preoperative systemic therapy for patients who become node negative, I would say as radiation oncologists, first have to consider the quality of the nodal assessment and whether we can really reliably say that we are confident the patient is node negative after neoadjuvant chemotherapy. We think of patients who are clinically node negative and then subsequently pathologically node negative as clearly safe to not have regional lymph node radiation. And those who present with stage 2 disease who have a pathologic complete response and don't have other adverse features are also able to be considered for avoiding regional lymph node radiation. And then we have the current clinical trial, NSABP B51, that will help us understand if other patients, more locally advanced patients, can have regional lymph node radiation omitted.